So hello everybody. In this video I'll be discussing the therapeutic regimens of chronic heart failure, and like I discussed before, the therapeutic regimens will be based on the etiologies, that is whether it is a case of preserved ejection fraction or reduced ejection fraction. So first I'll take up AHF-REF, that is heart failure with reduced ejection fraction. So I'd like all of you to please focus on this graph over here. So it is a graph plotted for mortality reduction versus incremental benefits, and I've taken this graph from Harrison's 20th edition. Over here we can clearly see why we give ACE inhibitors, beta blockers and mineralocorticoid receptor blockers in a case of heart failure with reduced ejection fraction, because as we can see, there is mortality reduction and a certain degree of incremental benefits as well. Then this drug, hydralazine isosorbide dinitrate combination, this has also shown to have promising effects in a setting of HFrEF because of the incremental benefits mainly. And then a few new drugs which are being considered to be included in the standard therapeutic regimen guidelines. These are omapatrilad, etanercept, endothelin receptor blockers, zamotrol, and monoxidil. Omapatrilad is an ACE inhibitor and a neutral endopeptidase inhibitor as well. Now, ACE inhibitors, so it will technically have the same pharmacological effect as the ACE inhibitors themselves, and the neutral endopeptidase inhibition. Now, neutral endopeptidase is an enzyme which breaks down the natriuretic peptides in our body. It's also called neprilysin. Now, if the natriuretic peptides are broken down in a patient where heart failure with reduced ejection fraction is set in, then we will never achieve a volume overload control, because as the name goes, there are natriuretic peptides. That is, there will be natriuresis, and excess water and sodium will be thrown out of the body via urine. And so natriuretic peptides are very essential in a patient where heart failure has set in. Next, etanercept. Etanercept is a TNF alpha antagonist, and as you can guess that TNF alpha is a pro-inflammatory cytokine, and if we block it, we might be able to reverse several of the pathologies which are found in a patient where heart failure has set in. Then there are endothelin receptor blockers. Now, endothelin has two receptors. One is ETA, another is ETB. ETA receptors, if endothelin acts on these ETA receptors, there is vasoconstriction, and this is an effect we are absolutely trying to block in any way in a patient where there is HFrEF. Then ETB receptors are there. If endothelin acts on the ETB receptors, there is vasodilatation, and there is nitric oxide release and prostacyclin release as well. So initially non-selective endothelin receptor blockers came out, and later selective ETA receptor blockers have also come out. Then there is zamotril. Zamotril is a partial beta-1 receptor agonist which has shown very promising results in a patient of HFrEF. And finally, monoxidil. Monoxidil I had discussed briefly in my sympathetic nervous system series. It is an imidazoline receptor agonist, and what happens is that the rostroventrolateral medulla has these receptors. Now, the rostroventrolateral medulla is responsible for the sympathetic outflow throughout our body by having a agonistic action on our intermediolateral cell column. And so if we manage to inhibit the rostroventrolateral medulla, then we'll have a good effect in a patient where HFrEF has set in. I'm sorry, I most probably said that monoxidil is an imidazoline receptor type 1 agonist. It's not agonist, it's an antagonist. Okay, so imidazoline receptor antagonism, which will suppress the RVLM, the sympathetic outflow from the intermediolateral cell column will decrease, and from here we can aim to block the cardiac remodeling process. Now, a few drugs which have been found to be ineffective when prescribed to patients in a setting of HFrEF. One of these is erythropoietin for anemia. Then there is warfarin for thromboembolism, SSRIs for depression, and statins for heart failure. So all these drugs have found to be ineffective to treat the cause for which they have been given if the patient has HFrEF. And a few drugs which are found to have very good effect. One of this is fish oil. Fish oil will have a very good effect and reduce the triglyceride levels in our body because they are rich in PUFA, that is polyunsaturated fatty acids. Then there is ivabradine. Ivabradine is a very novel drug. It acts by three main mechanisms. One is that it inhibits the funny current channel in the sinoatrial node. Then it is also a weak beta blocker, and it's also a PFOX inhibitor. PFOX inhibition ensures that the heart muscles derives all its energy via aerobic glycolysis only. And of course there is the little bit of pharmacological effects of beta blockers, and we also managed to inhibit the funny current channels and thereby achieving a control of the heart rate as well. It is mainly prescribed to patients where the HF-REF is not being controlled despite adequate RAS therapy, RAS blocking therapy, and there is a heart rate more than 70 beats per minute. And there is also promising results obtained from iron supplementation to treat anemia in a setting of HF-REF, though there is still some question marks regarding its therapy. And this is a very important topic. What is the role of digoxin in heart failure? Now, earlier digoxin was being routinely prescribed to patients with heart failure. However, in Harrison's 20th edition, there is information about a trial known as the DIG trial, which showed that there is no mortality benefit and no improvement of QOL. What is QOL? Quality of life. There is no improvement of the quality of life and no mortality benefit following digoxin therapy. So nowadays, digoxin hasn't been totally discarded. It is reserved for the treatment of patients who remain symptomatic despite adequate neurohormonal blockade and volume control. Okay. So without much ado, let's jump straight into the standard therapeutic guidelines. We must always start with diuretics, because they will decrease the congestive symptoms, they will slow the ventricular remodeling, and it will also decrease the LV filling pressure. And so the drug of choice is Lasix or furosemide, which we give 40 milligrams OD. And another drug which is routinely being prescribed nowadays is torsemide, which is again a high ceiling or loop diuretic. It is 20 milligrams tabs are given, but the drug of choice is still furosemide. Now we must add an AC inhibitor or an ARB, that is an aldosterone receptor blocker. Now we need to start these drugs at a very low dose. Why? Because if we block the AC enzyme, then there will be an accumulation of products which are present just before the AC step in the RAS axis. Okay, and so there is hyperreninemia if we give AC inhibitor, and very high levels of renin may actually cause postural hypotension in a patient of HF-REF. So we need to start at low doses and gradually up titrate. For example, we may give enalapril. Enalapril is given 25 milligrams BD, and it is gradually up titrated to 10 to 20 milligrams BD. If it is well tolerated, we may switch to ARNI. Now ARNI, or its fancy name, that is LCZ696, is a very novel drug, and its therapeutic benefits were outlined by the Paradigm heart failure trial. What is ARNI? AR stands for an aldosterone receptor, and NI stands for neprilysin inhibition, or a neprilysin inhibitor. So in ARNI, we have a ARB, that is valsartan, and in a 50 milligram tablet there is 26 milligrams of valsartan. And we also have a neprilysin inhibitor, that is sacubitril. And in 50 milligrams of ARNI, we have a 24 milligrams of sacubitril. So we give ARNI as 100 milligram BD dosing, which is gradually up titrated to 200 milligrams BD dosing. Okay. And following ACE inhibitor and ARB therapy, we will add a beta blocker midway. Okay, so what are the beta blockers prescribed or recommended in a case of HF-REF? These are metoprolol, which is started at 12.5 milligram QD and up titrated to 200 milligrams QD. QD stands for every 8 hours. And again, why are we starting this at such a low dose and gradually up titrating it? So you need to realize that if we straight away give beta blockers at such a high dose, there will be decompensation of the heart failure and the patient will land up with ADHF. So metoprolol, then we can also give bisoprolol, 1.25 milligrams QD up titrated to 10 milligrams QD, and we can also give carvedilol as 3.125 milligrams BD up titrated to 25 to 50 milligrams BD. If there is no response following RAS inhibition and beta blocker therapy, then we need to add spironolactone. Spironolactone we gave as 25 milligrams QD. If there is still no response, then we need to switch to ivabradine. And if there is still no response, then we need to add isosorbide dinitrate or isosorbide dinitrate hydrolysine combination. It is started as 20 milligrams of ISDN and 37.5 milligrams of hydralazine, and I titrated to 40 milligrams of ISDN and 75 milligrams of hydralazine. Okay, so that's the standard therapeutic regimen of HF-REF. And finally over here, as you can see, in a patient where HF-REF has set in, the ejection fraction will gradually fall over the years due to secondary damage. But if we manage to start a therapeutic regimen early and the patient has managed to maintain a regular drug intake, then we will able to reverse a lot of these changes. Now the compensatory mechanisms will initially reverse a few of these changes, but like I explained it to you before, these will come at the cost of increased myocardial oxygen demand, and ultimately there will be decompensation. So that's that with respect to the treatment of HF-REF. Finally, let's come to the treatment of HF-PEF, that is heart failure with preserved ejection fraction. Now till date there have been no real evidence of which drug will have the most beneficial effect in a patient with HF-PEF. Various trials are ongoing. The latest guidelines issued by the American College of Cardiology are these. If a patient has heart failure risk, then we need to straight away treat the hypertension and hyperlipidemia. If the patient has diastolic dysfunction but without symptoms, then we need to treat hypertension with thiazide diuretics or ACE inhibitors or ARBs or non-DHP calcium channel blockers like verapamil or diltiazem. If the patient is symptomatic, and is also hypertensive, then we need to treat the volume overload with diuretics and consider use of a beta blocker or ARB or ACE inhibitor. And finally, if the patient is symptomatic and has no hypertension, then again treat the volume overload with diuretic and consider adding an ARB. So these are the standard issue guidelines for treating a case of HF-PEF. Again, various clinical trials are ongoing to ascertain which drug has the maximum mortality benefit, and also these guidelines are likely to be changed in the future when we will get some definitive results. And one drug which had initially shown a lot of promise in the treatment of HFpEF, that is nebivolol. Now, initially, researchers indicated that there is improvement of exercise tolerance, but they were subsequently dubbed as dubious by a whole lot of other researchers. So the role of nebivolol is still controversial. Hopefully, we'll get a definitive result in the near future. So that's that with respect to the treatment of heart failure, chronic heart failure. I hope you enjoyed this series, and please let me know in the comment section below how was it, where and when I need to improve, and what should be the next topic that I take up in pharmacology. So thank you.